Hi guys, we're going to be talking about resistance exercise for the impaired muscle performance. Be going over quite a few of the definitions that's involved. So by definition, muscle strength is the greatest measurable force, muscle or muscle group to overcome resistance during a single maximum effort. And functional strength relates to the ability of the neuromuscular system to produce appropriate amount of force during functional activities in a smooth and coordinated manner. Now, when it comes to strength training or strengthening exercise, that is the muscle force to raise, lower, or control heavy external loads for a relatively low number of repetitions over a short period of time. Most common neural adaptations increase muscle fiber size. Definition for power. So muscle power that is related to the strength and speed of movement and is defined as the work. And work is defined as force times distance. That's how you get work. And that is produced by a muscle per unit of time. And that formula would be force times distance divided by time. So power is the rate of performing work and the rate at which a muscle will produce a force and the relationship that would be between force and velocity, and these key factors that affect the muscle power. Now, a single burst of high intensity activity, maybe from lifting a heavy piece of luggage onto an overhead rack or performing high jumps, or repeated bursts of less intense activity would be like such as climbing a flight of stairs. Now for power training, power can be gained by either with increasing the work of a muscle, but it must perform during a specified period of time, and reducing the amount of time required to produce the work. So the greater the intensity of the exercise and the shorter the time period taken to generate force, the greater the muscle power. So for endurance, that is the ability to perform repetitive or sustained activities over a prolonged period of time. Cardiopulmonary endurance, that means just like total body endurance, that would be associated with repetitive dynamic motor activities that would maybe include walking, cycling, swimming, or upper extremity ergometry, like the UBE, and large muscles of the body. With this endurance, it's the ability of a muscle to contract repeatedly against an external load, generate and sustain tension, and resist fatigue over an extended period of time. This means aerobic power. So make sure you look over aerobic and anaerobic and the different properties for that too. I know we'll be talking about that a lot with cardiopulmonary, but make for sure you look over that. When it comes to balance and posture, all ADLs require muscle and cardiopulmonary endurance. And so you could have strength, but it doesn't necessarily mean you have to have endurance of the muscles. Now with endurance training, you're going to be using muscle force to raise, lower, and control a light load over many repetitions, prolonged period of time, and you're going to increase in oxidative, which means oxygen, and metabolic capacities with aerobic training. With this endurance training, you'll have a more positive impact on function than you would on strength training. So with that meaning, like with ADLs or things that you do for prolonged periods of time, is more functional because a lot of our functional motions are repetitive. So endurance training is going to be more beneficial. With endurance, you're going to have lower resistance in all exercises, less joint reaction forces or harm because you're not putting so much stress and load on them. You'll have less soft tissue irritation and more comfortable than heavy weights. So you're doing more of a low load, long duration when it comes to endurance. So we're going to look at what's called the overload principle. A muscle must be challenged to perform a level greater than it is accustomed to improve muscle performance. So if you're not challenging it, if you're not stressing it, then you're not going to improve muscle performance. So, after the muscle has adapted, if remained constant, muscle performance can be maintained but not increased. So this is like a great example is when maybe an athlete has plateaued, right? So you have, after the muscle has adapted, And if they do the same amount of work, if it remains a constant amount of, load, then they're not, and if there's not more load placed on it or there's not a progression in exercise, then, it's going to be maintained, but that muscle performance does not necessarily increase unless there's more load placed. So you would need to have an increase in challenge, either that be more intensity and volume. So intensity is how much external resistance. Volume would be more of repetition sets or frequency, and it can be adjusted to increase demands of the muscle. With strength training, you would be doing increments, and progressively that would be increased. With endurance training, you're going to increase time and number of reps performed rather than the amount of external resistance. So like I said, low load, low resistance, and strength training is a higher load to have more muscle tension placed on it and less reps. So the overload principle is definitely going to depend on the pathology, age, healing, the patient's response and goals. The muscle and body systems, they must have time to adapt to demands of increased intensity or volume. Now we're going to be talking about what's called the SAID principle, and that means specific adaptation to imposed demands. And this is another muscle performance program. It will help determine exercise parameters to create a more specific training that'll meet your patient's functional needs and goals. And the Wolff's Law, this is a body system that adapts over time to the stresses placed on it. That's what the Wolff's Law means. The specificity of training is, looking at what is the desired functional activity. Should the program mimic more strength, power, or endurance? May the patient might need to focus more on endurance and strengthening. And, when you're looking at training, you're looking at the optimal mode, which just means type, and the velocity of exercise. So for example, if a patient is having difficulty ascending and descending stairs, you need to incorporate exercises eccentrically and concentrically in weight-bearing position and progress, to the desired speed. So that would be more a task-specific practice. Transfer of training, another word for that would be cross-training. And this is very limited basis based on velocity, type and mode of exercise. And the training would be from muscle strength, have a moderate improving of muscular endurance. But endurance training has little to no effect on muscle strength. So if desired strength, it's more optimal to at one speed of exercise. So most studies support a program that closely replicates the desired functional activities, which would be specificity of training. Reversibility principle, that would mean detraining. So it'd be going in the opposite direction. So, which means basically it only takes about a week or two to have a reduction in muscle performance. So it's important to incorporate gain in strength and endurance into ADLs as early as possible in a rehab program, also to maintain it with a maintenance program, patient education, resistance exercise as a lifelong fitness program. So even when your patients are discharged from therapy, it doesn't mean that they're stopped exercising because they're going to lose what they gained. So there are some different factors that influence the tension generation in normal skeletal muscles. So depending on the amount of energy stores and blood supply, fatigue, so muscle fatigue, cardiopulmonary fatigue, threshold to fatigue, and factors that influence. So it's important to understand that like force producing capacity of normal muscle during an active contraction is fundamental to understand how the neuromuscular system adapts to resistance training. Morphologically, biomechanical, neurological, metabolic, and biochemical factors, these will all affect the tension generating capacity of normal skeletal muscle. And each of these factors, they contribute to the magnitude, duration, and speed of force production and the muscle susceptibility to fatigue. So with energy stores and blood supplies, the muscle needs adequate sources of energy to contract, for it to generate tension and to resist fatigue. So muscle also requires an adequate blood supply to provide the tissue with oxygen and nutrients and to transport waste products from muscle to other organs. The degree of vascularization is related to predominant fiber types that constitutes the tissue, which directly affects the fatigue profile of the muscle. So the three main energy systems, that would be the ATP-PC system, the anaerobic glycolytic, there you go, lactic acid system, and the aerobic system. So we'll look at each one of those two and by definition. And with each one of these, when it comes to muscle, make sure that you look over there's a table about muscle types, like type 1, type 2 muscle fibers, and which ones are more fatigue resistant and which ones are fatigued more easily. So next we'll talk about fatigue. And by definition, fatigue is a complex phenomenon and it affects muscle performance and must be considered in a resistance training program. So the muscle's response to fatigue, because of the constant contract to a load, then there is a response to that. So, if there's a gradual decline in the force producing capacity of the neuromuscular system, then this means that there's decreased muscle strength. If there's disturbances in the contractile mechanism of the muscle itself, and maybe that's associated with a decrease in energy stores or insufficient oxygen, or if there's reduced sensitivity and availability of intracellular calcium, or if there's a buildup of hydrogen ions, then perhaps there's reduced excitability at the neuromuscular junction or inhibitory protective influences from the central nervous system. Now we'll get into the different muscle fiber types of type 1 and type 2. So type 2, that's called phasic fast twitch muscle fibers, and they are further divided into two additional classifications. That would be types 2A and 2B, and they are based on contractile and fatigue characteristics. So type 2 fibers, they will generate a great amount of tension within a short period of time. So if you want to think about, a lot of times I refer that to sprinting, right? So they're going to have a great amount of excitability and tension only for a short period of time. You're going to be generating type 2 muscle fibers. For type 2B, that is more geared toward anaerobic metabolic activity and having a tendency to fatigue more quickly than type 2A fibers. Now for your type 1, that is your tonic slow twitch muscle fibers, they generate a low level of muscle tension and can sustain the contraction for a long period of time. So that's going to be a lot more of your endurance type activities. Those are the type of fibers that you're going to kick into for a longer duration, and they're going to be more fatigue resistant. So they are going to be more aerobic metabolism, and they are definitely more fatigue resistant compared to type 2A. You're going to definitely see a lot of these type 1 slow twitch muscle fibers and more in the postural muscles because this allows them to sustain a low level of tension for a longer period of time. And, functionally with postural muscles, they're suited to hold the body erect against gravity or stabilize against repetitive loads. On the other end of the fatigue spectrum, muscles with a large distribution, they're going to have more type 2B, which is fast twitch phasic fibers, and they can produce high increases of tension over a relatively short period of time. These muscle functions are to move heavy loads, but are sustainable to fatigue. So to look at the signs and symptoms developed during resistance exercise, you should be able to be aware that if you decrease the load on the exercise muscle or stop the exercise and shift to another muscle group, this will allow time for the fatigued muscle to rest and recover. Talk a little bit more about cardiopulmonary fatigue. So there is a systemic diminished response in the individual to a stimulus as a result of prolonged physical activities such as walking, jogging, cycling, or repetitive work. So cardiopulmonary fatigue is related to the body's ability to use oxygen efficiently and it's associated with endurance training is a cause of a combination of decreased blood sugar, which would be glucose levels, and decreased glycogen stores in muscle and liver, a depletion of potassium, especially in the older adult. For the threshold for fatigue, so there is a baseline of the adaptive changes that it can be performed, which would be a threshold, and it's a length of time a contraction is maintained or number of reps an exercise can be performed. There are several different factors that can influence fatigue. Maybe it's because of their lifestyle, sedentary or active. Their factors to influence fatigue could be health status and what their threshold looks like to fatigue. Patterns of fatigue, a lot of times medication could be the culprit or different types of diseases. One of the number one pathologies you're going to hear about fatigue is going to be multiple sclerosis or MS. Usually patients feel better early in the morning than evening, and evening they have increased fatigue and weakness. You'll also see patients with cardiac, pulmonary, or cancer, and they are fatigued more readily and they require a longer recovery from exercise. And this is because of the deficits or compromise of the oxygen transport system, and they fatigue more easily and they require longer recovery time. Some other factors is environment. So, depending on the air, the room temperature, and altitude, this can all influence fatigue. So like if you've ever ran before in a really hot condition environment, then you're going to be more fatigued easily. So it'd be better to run in the morning instead when there's cooler temperature. So next we'll talk about is recovery from exercise. So if you were to recover from an acute exercise, and this will be a force producing capacity to where the muscle will return to 90 to 95% of the pre-exercise capacity. This usually takes about 3 to 4 minutes to recover, and with the greatest proportion of that recovery will occur in the very first minute. When it comes to oxygen and energy stores, they will replenish quickly in muscle recovery. Lactic acid is removed from skeletal muscle and blood within approximately 1 hour after exercise, and glycogen stores are replaced over several days. There are several studies that show that over several decades have demonstrated that if light exercise is performed during the recovery period, this is considered active recovery, that recovery from exercise occurs more rapidly than with just total rest, which would be passive recovery. So it's better for a faster recovery if you incorporate light exercise, to result of, to help with neural as well as circulatory influences. Now, when you come to muscle performance, such as strength, power, or endurance, it only improves over time if a patient is allowed adequate time to recover from fatigue after each exercise session. So if there is not enough rest, then a patient's performance can plateau, or they can start or be more of a deteriorating. So that would be more of overtraining. So evidence of overtraining or overwork, weakness may become apparent with that. It's shown that fatigued muscles are more susceptible to acute strains. Now, depending on the age, earlier childhood and pre-adolescence, they have a linear increase in muscle fiber numbers. So muscle fiber types are more balanced by age 1. Boys are 10% stronger than girls from early childhood to puberty. Training-induced strength gain before puberty results in neuromuscular adaptation in the muscle mass. So just, before puberty, there's, what's called neuromuscular adaptation. You're not actually going to see a difference in the muscle fiber mass. Resistance training can cause injury due to impaired musculoskeletal system. So therefore, they can have an epiphyseal avulsion fracture. When it comes to toddler elementary physical activities, this should promote fitness and performance. Then it should focus on resistance training and learning about motor skills. So there's not a good agreement of when resistance training should take place in the pre-pubescent children. So it's popular for older children to participate in sport-specific training programs to reduce injury. So it's always important it's good to establish a safe program with realistic goals. So adolescence and puberty, there's a rapid acceleration of muscle strength, especially in boys. So they'll increase 30% per year between ages 10 and 16, and muscle mass peaking before strength. Girls will peak strength develops before peak mass. In the young and middle adulthood, women peak in mid-20s and men by age 30. And then there is a strength decline 1% per year, so slower rate for active adults and sedentary. There's a participation in moderate activities several times a week is what is recommended by the ACSM. Now by late adulthood, that would be by 60s and 70s, tension generating capacity of muscle declines significantly by 15 to 20% per decade for men and women. And that'll increase 30% per decade after that. So there's an active decline is only 0.3% decrease. Well, if they're active, which I meant to say, if they're active, then there's only decline is less, only 0.3% decrease per year. So also declines in speed of muscle contraction, endurance, ability to recover from muscle fatigue occur with advanced age. And there's also decreased muscle power with age, and they have a strong relationship with functional limitations and disability than does muscle strength. There's also decreased quick responses, such as getting up from a chair, which is often seen. When it comes to physiological factors, this can definitely influence muscle performance and how a person moves based upon what their mental status is, what they are fearful of pain, their injury, re-injury, depression, impaired attention and memory, head injury, side effects of medication. All of these can adversely affect their ability with motor function. There are positive influences of psychological factors where they can improve function with motivation. And patients that are attention to detail or to a task, they're able to follow commands. Those that are able to respond to environmental factors and attention to form, a training program, that would be necessary for patient safety, and this will have optimal long-term training effects. It's always good to, provide motivation, because if there's lack of motivation, there's lack of effort or performance. So motivating our patients and educating them, there's so many different ways that we can show increased motivation. All right. So going back to those neural adaptations, that's initial rapid gain in tension generating capacity of skeletal muscle from a resistance training program. This is largely attributed to neural responses. So just remember, like anytime you start a strength training program and you're like, oh, I'm feeling stronger. Well, that's attributes to these neural responses. Based upon EMG or electromyographic activity during 4 to 8 weeks of training, there's no evidence of muscle fiber hypertrophy. So after muscle hypertrophy has plateaued late into a program, that would be neural activity. Now for skeletal muscle adaptations for hypertrophy, that just means increase in the size of the individual muscle fiber. And it's caused by increased myofibrillar volume after an extended period of moderate to high intensity resistance training. This usually occurs by weeks 4 to 8 weeks, but it can be possibly as early as 2 to 3 weeks, depending on if they perform very high intensity resistance training. So hypertrophy is important adaptation and will definitely account for muscle strength gains. And the muscle strength gains is because it's resulted in increased proteins of actin and myosin. Also has to do with how the uptake of amino acids. So, just remember high volume, moderate resistance exercise performed eccentrically, the type 2B muscle fibers that appear to increase in size most readily with resistance training. Hyperplasia, so with heavy resistance training, there's an increase in size due to hyperplasia, which just means increase in muscle fibers. But there's a lot of evidence that is controversial if hyperplasia even exists. There are also vascular and metabolic adaptations. So opposite with endurance training. With muscle hypertrophy from high-intensity, low-volume training, capillary bed density actually decreases because of the increased number of myofilaments per fiber. So like athletes who participate in heavy resistance training, they actually have fewer capillaries per muscle fiber than endurance athletes and even untrained individuals. There's also changes in metabolism, so they can have a decrease in mitochondrial density, and this will also occur with high intensity resistance training. So this change is associated with reduced oxidative capacity of muscles. There's also adaptations of connective tissue, so that would be tendons, ligaments, and connective tissue and muscle. That would be the musculotendinous junction, to where they'll have increased tendon strength of where it occurs. Ligament bone interface, where they'll have increased ligament strength. With that resistance training and tensile strength will increase to support strength and size change of muscles. So if they have stronger ligaments and tendons, they're going to be less prone for injury. And connective tissue and muscle will thicken to support the enlarged fibers. And with endurance training, there's non-contractile soft tissue strength develops more rapidly than other types of resistance exercise. When it comes to bone mineral density is highly correlated with muscle strength and also with muscle activity throughout the lifespan. So physical activities and exercises that are with weight bearing are recommended to minimize this age or to prevent this age-related bone loss that occurs. And this also will help reduce the risk of fractures and will improve bone density, you know, how it would be with osteopenia or osteoporosis, especially if it's already present. There is mixed evidence to support, you know, if weight bearing does increase or maintain bone mineral density. Some other studies also showed that young women or postmenopausal women, that they didn't have a significant increase in bone mineral density with resistance training. But however, those studies were not combined with weight bearing activities, which would have been important, right? It says that for, you know, to do exercise for 9 to 12 months, this will significantly increase bone mass. Now, ACSM, or American College of Sports Medicine, they they suggest to use the FIT principle especially for resistance training or any type of training, but FIT means frequency, intensity, time, and type of exercise. As we mentioned before about the SAID principle, you know, you want to have the determinants of, you know, resistance exercise. It should be specific based upon the patient's desired goals, and also looking at additional factors to see if there's a different kind of cause of this muscle performance deficits. And that could be because of age or their medical status, the mental status. So all of those should be, you know, align with the patient's goals. And it's also important to make for sure that, you know, your target muscle groups and the appropriate positioning is very important on how to target them correctly. You want to make for sure that your patient avoids compensation or substitute motions. So alignment and gravity. So we already know that gravity is very important for positioning, and you know, of how against gravity or with the lines of gravity. So being able to identify what is going to be the best position, and also for stabilization of body parts to avoid that substitution of motion. There's also some external stabilization, such as bands, or, you know, external stabilization from USA PTA or equipment or table for support. So that's to stabilize the patient with performing exercises. There's also internal stabilization, like using isometric contractions, like a single leg stance strength for supporting the leg to perform contralateral hip abduction, as you've seen in the PowerPoint slide here. Because if not, then the supporting limb would buckle. So next we're going to look at intensity. So intensity is defined as the amount of external resistance during each repetition. Training is the load or muscles loaded, either the weight is raised, lowered, or held. Again, the overload principle, so performance is only going to improve if the load is greater than what is usually experienced, and it should be a gradual increase in the amount of resistance in the exercise program. So a submaximal versus maximal exercise, that will depend on the functional outcomes of the program. So, submaximal is looking at, the healing of the tissues, the age, the health, the fitness level, and impairments. So if there is increased pain with resistance exercise, that means that the intensity level is too great. So the saying no pain, no gain is definitely not true. So those with cardiovascular risk, they require, breathing in between, like for vital capacity breathing for each rep too. Repetition maximum, or RM, is defined as the greatest amount of weight or load that can be moved with control through the full available range of motion a specific number of times before fatiguing. So there's two main reasons of determining rep max. So one is to identify an individual or initial exercise load, so the amount of weight to be used during exercise for a specified number of repetitions, and also to document a baseline measurement of the dynamic strength of a muscle or muscle group against which exercise-induced improvements in strength can be compared. Now, a 1 rep max population, or 1 RM, is for healthy young adults and athletes as well as active older adults. It is not safe to use for patients with joint impairments or patients who are recovering or at risk for soft tissue injury, or patients with known or at risk osteoporosis or cardiovascular pathology. So, make for sure that you understand of what general population would most benefit of a 1 rep max as a baseline measurement that I just mentioned. So, it's also important to know how many repetitions can be completed through the full range before the muscle begins to fatigue. So let's say, for example, your patient performed 6 reps and they were completed. So the baseline resistance would be based on a 6 RM. So remember, a sign of fatigue is the inability to complete the full available range of motion against the applied resistance. Some alternative methods to look at determinants of resistance exercise would be body weight percentage, and you would estimate the amount of external resistance and strength training with using like isokinetics. Another is called a training zone, and that is percentage of a 1 rep max. So sedentary untrained, you would do 30 to 40% of the 1 rep max. Highly trained would be 80%. Healthy untrained is 40 to 70. So patients with a deficits in muscle strength or to train for endurance, you would do a low load at 30 to 50% is safe yet challenging. Next we're looking at is volume. So in resistance training, volume of exercise, this looks at the total number of repetition and sets of a particular exercise during a single exercise session, and that is multiplied by the intensity of the exercise. So with this combination of repetitions and sets is not and should not be used for all muscle groups. So the higher the intensity or external resistance, the lower the number of repetition and sets are possible. And the lower the external resistance, the greater number of repetition and sets are possible. Therefore, the external resistance will directly dictate of how many repetition and sets are possible. So for reps, let's say you did 10 reps with a 20-pound load, that would be designated as a 10 RM for the 20 pounds. For average untrained adults, a load that is equivalent to 75% of the 1 rep max is able to complete approximately 10 repetitions before needing to rest. 60% would be about 15 repetitions, 90% intensity, only 4 or 5 repetitions are usually possible. For sets, so after a set of reps, rest then perform the same amount of reps. So you would do like 2 sets of 10. So, or 2 to 4 sets are recommended for adults, and 1 to 6 sets have yielded positive training effects. So those that do single set exercises at low intensity are more uncommon for early phases of resistance exercise programs and maintenance programs of doing multiple sets to progress in the program. Now, when it comes to strength, 3 sets of 10 for strength gains. That is a threshold of 40 to 60% of maximal effort. It is for moderate recommendation, 60 to 80% are fatigued after 8 to 12 reps for 2 or 3 sets. So when fatigue no longer occurs after that target number of reps, you'll increase the resistance to overload the muscle once again. Now, when it comes to power, modifying the speed and intensity of training, that would be 20 to 70% of a 1 rep max and rate of exercises with explosive or ballistic exercises. So studies show that small increase in power would be 3.8 sets of 6.4 reps performed rapidly at 81% of a 1 rep max for 3 to 4 sessions per week for both upper extremity and lower extremity to improve power. Now for endurance, this is many reps against a submaximal load. So example would be to do 3 to 5 sets of 40 to 50 reps against a low amount of external resistance, light, grade, or elastic resistance. So when increasing the number of reps or sets can become inefficient, the load can be increased slightly. You can also perform isometric contractions for a longer period of time, and endurance training can be initiated very early in program without risk of injury or healing. So just to keep note, when injured muscles are mobilized, the type 1 slow twitch muscle fibers will atrophy at a faster rate compared to the type 2 fast twitch muscle fibers. Some different things to make for sure that you know is that the correct order for exercise is that you want to do the large muscle group should be exercised first before small muscle groups. And multiple joint exercises should be performed before single joint exercises. So like for instance, if you did a squat, that's going to be targeting large muscle groups and multiple joint multiple joint exercise. It's also important to know after a warm-up, higher intensity exercises should be performed before lower intensity exercises. Now for frequency, that's going to depend on the number of exercise sessions per day or per week for a resistance exercise program. It's also going to depend on the specific muscle groups targeted, and also looking at intensity, volume goals, health status, and the response to training. So with greater intensity and frequency, there's more time needed in between sessions to recover from muscle fatigue. And some exercises should be performed less frequently than others because they require greater recovery time. So just note that high intensity eccentric exercise is associated with greater micro trauma to soft tissues. So that would be with eccentric. And a higher incidence of delayed onset muscle soreness than compared to concentric. So therefore, it's important to have rest intervals between exercise sessions that are longer and the frequency of exercises is less for eccentric compared to the other forms. So for early post-surgical patients, it's good to have short sessions several times a day with the intensity of reps to be low. This will minimize the risk of muscle atrophy. Now talking about duration. So that would be the total number of weeks or months a program is carried out for. So for hypertrophy, it would be good for it to be 6 to 12 weeks of training that is usually required. So for rest, this would be the recovery period. This is important for muscle fatigue to offset exercise-induced delayed onset muscle soreness. So it's important to make for sure that you integrate rest into exercise. So every 2 to 3 minutes after each set for moderate intensity, and shorter for low intensity and longer rest breaks for high intensity exercises. So next we'll talk about is the mode of exercise, meaning what kind of form of exercise. So there's static and dynamic muscle contractions. Static contractions, that would be like your isometric contractions and like muscle sets. And then dynamic resistance exercises, that would be more like using concentric and eccentric contractions or both. So what the velocity of limb movement, and if it's held in a consistent rate control, this is termed isokinetic contraction. And it's usually under controlled conditions. So for forms of resistance, manual and mechanical resistance, that can be applied externally. And also with mechanical resistance, you can have a constant or variable load, such as free weights or weight machines. With accommodating resistance, you can have like an isokinetic dynamometer, and that will control the velocity and with adjusting the external resistance. You can also utilize body weight or partial body weight as a source of resistance in exercise, and especially, can occur in an anti or gravity position, minimize gravity position, and then progress with that. So just to go over to, anaerobic exercise, that's going to be a high intensity effort, low number of repetitions, so muscles rapidly fatigue at near maximal intensity. That would be with strengthening exercises. And then aerobic exercise is at low intensity, high repetition effort over an extended period of time. And that mode will increase muscular or cardiopulmonary endurance. The full arc and short arc. So full arc is full range of motion to develop strength over an entire range of motion. And a short arc, it would be a portion of available range of motion due to pain and instability, protect healing tissues after injury or surgery. So for example, like for the shoulder versus gravity to gravity minimized position, resistance, if only can perform 75 degrees of active range of motion shoulder flexion, you can put them in a gravity minimized position. We've already talked about concentric before, so that would be muscle shortening. The force the muscle can generate will decrease in the very shortened position. Eccentric is the lengthening, so there's force applied on the muscle and while it is lengthening. So stability is defined as quick changes of direction during functional movements for mobility, and active movement, static and dynamic strength for stability. So when it comes to functional tasks, it's going to require a combination of muscle strength, power, and endurance. Also require more motor capabilities and produce slow and controlled movements, rapid movements, and repeated movements for long-term positioning. It's good to apply resistance during exercise in different anatomical planes, diagonal patterns, and even combined task-specific movement patterns. It's important for the strategy for a progressed resistance exercise program. Pushing, pulling, lifting, and holding activities can initially be done against a low level of resistance for a low number of repetitions. So it's important for you as a PTA to be able to make those informed decisions about the intensity, volume, and order, the frequency, rest interval, and other factors that we already discussed. So with manual resistance, this is resistance that you would give towards the patient. So early stages of an exercise program is when it would be included. So when to initiate for muscle strengthening, especially if it's too weak and can only overcome only minimal to moderate resistance. And it's useful when the range of motion movements need to be carefully controlled. So also talking about isometric exercise or static, so where the muscle contracts and produces force when there's no visible joint movement, like especially your posture muscles, they perform isometrics all day long when you're in upright position. So repetitive isometric contractions, for example, if you have a set of 20 per day, held for 6 seconds each against near maximal resistance, this has been shown to improve effective for isometric strength. There is also, it's called a cross exercise effect, to where a limited increase in strength on the contralateral side of the muscle groups, as if it's a transfer of training, and it's been observed more so with maximum isometric training. So muscle setting, an example would be like doing quad sets 10 times for 10 seconds each, can help with during the acute stage of healing, and this will only improve strength in very weak muscles and can slow the muscle atrophy and will help maintain mobility. There's also stabilization exercises to where you can do a submaximal level of co-contraction to improve postural stability and dynamic joint stability, like isometric contractions against resistance. That could be in an anti-gravity or weight-bearing positions, like doing rhythmic stabilizations of the shoulder, using like a body blade with the shoulder, like, or even doing core stability and different positioning. You can also incorporate multiple angle isometrics to where they'll do multiple positions of range of motion with holding the muscle, recruiting the muscle. So intensity of exercise, that's really going to depend on which joint and position and the greatest amount of isometric force generated at the joint angle, where maximum actin and myosin protein overlap with that cross bridge formation. So an intensity of at least 60% is needed to improve strength, but it needs to be pain-free. So once, this is all talk about isometrics, but once isometric strength has been achieved, you need to progress with resistance or increase with different angles to overload the muscle once the isometrics become too easy. So a duration of 6 seconds and no more than 10 seconds due to muscle fatigue, peak tension and metabolic changes to occur in the muscle. So sets of reps, contractions for 6 to 10 seconds each. You can also incorporate Russian E-stim, but that's just going to target type 2 muscle fibers. But you can combination with isometric contractions, that's going to generate type 1 muscle fibers while you're doing, the Russian E-stim. Some other things to make for sure as a precaution that your patients are breathing and not performing the Valsalva maneuver during isometric contractions. So concentric and eccentric exercises, they can be applied in several different ways. You can use constant resistance, like such as body weight or free weight or simple weight pulling machine. You can use a weight machine or elastic bands to provide variable resistance, or isokinetic device that can help maintain the velocity of limb movement. Just note concentric muscle contractions, they will accelerate body segments, and eccentric contractions are going to be deceleration of body segments. Eccentric exercises are definitely appropriate after a musculoskeletal injury or surgery and conditioning programs to reduce the risk of injury or re-injury associated with activities, especially that's involved with high intensity deceleration, quick changes of direction, or repetitive eccentric muscle contractions. Eccentric training is also thought to improve sport-related physical performance. So traditionally, training that emphasized high-intensity eccentric loading, such as eccentric isokinetic training or plyometric training, has been initiated during the advanced stages of rehab to prepare a patient for high-demand sports or work-related activities. So note a maximum concentric contraction will produce less force than a maximum of eccentric contraction under the same conditions. And with a concentric contraction, there's a greater number of motor units that must be recruited to control the same load compared with an eccentric contraction. So this suggests that concentric exercise has less mechanical efficiency compared to eccentric exercise. So, consequently, it requires more effort by a patient to control the same load during concentric exercise than during eccentric exercise. So as a result, when a weight is lifted and lowered, maximum resistance during the concentric phase of an exercise does not provide a maximal load during the eccentric phase. It's also good to have a precaution that there is a greater stress on the cardiovascular system, which means increased heart rate and arterial blood pressure during eccentric exercise compared to concentric. And this is possibly due to the greater loads that is used for eccentric training. This is very important to improve or incorporate rhythmic breathing during high intensity exercises. For energy expenditure, eccentric exercise is more efficient at the metabolic level compared to concentric. So eccentric muscle contractions consume less oxygen and energy stores compared to concentric. Therefore, the use of eccentric activities such as downhill running may improve muscular endurance more efficiently compared to concentric activities because of muscle fatigue that occurs less quickly with eccentric. Now, when it comes to specific training, eccentric training is more mode specific compared to concentric. Eccentric activity or exercise also appears to be more velocity specific compared to concentric. Now, with the cross-training effect, concentric and eccentric training, there is a slight increase in strength that occurs over time in the same group of the contralateral unexercised extremities, but there's no evidence to support impact on functional abilities. So exercise-induced muscle soreness. So with repeated and rapidly progressed high-intensity eccentric muscle contractions, they're definitely associated with a higher significantly incidence rate of the DOMS of delayed onset muscle soreness compared to the high-intensity concentric exercises. So the most common system of dynamic resistance training is known as progressive resistance exercise, or PRE. There's also a dynamic exercise against constant external resistance known as DCER, and is a form of resistance training where the limb will move through a range of motion against a constant external load, which is provided by free weights such as handheld or cuff weights, weight machines, or weight pulley systems. If the load is less than the torque generated by the muscle contracts concentrically and accelerates the load. If the load exceeds the muscle's torque production, the muscle contracts eccentrically to decelerate the load. So the DCER exercise definitely has a limitation. So when lifting or lowering a constant load, the contracting muscle is challenged maximally and only to the point in the range of motion in which the maximal torque of the resistance matches the maximal torque output of the muscle. So you need to be aware as the PTA of this changing external torque of the exercise and the changing length tension relationship of the muscle, and modify body position and external resistance accordingly to match where the range of the maximal load needs to be applied. With variable resistance exercise, this is a form of dynamic exercise that addresses primary limitations of dynamic against a constant external load. So this is designed for resistance equipment that impose levels of resistance to contracting muscles, to load the muscle more effectively at multiple points in the range of motion. The resistance is altered throughout the range by means of a weight cable system and moves over an asymmetrically shaped cam or lever arm system. Velocity dynamic exercises are most often performed at a relatively slow velocity to avoid momentum and uncontrolled movements, which therefore can alter the safety of the patient. Here you can see a biodex or isokinetic exercise, And that is a form of dynamic exercise to where it controls the velocity of the joint angular motion and is determined at a constant velocity. So an isokinetic exercise, there's a velocity of the movement, not the load that is maintained during the effort. One advantage is that it has the ability to provide resistance to the opposing muscle groups at a joint referred to as reciprocal training. So for instance, isokinetic can be said to where the patient will perform concentric contraction of the quadriceps muscle followed by concentric contraction of the hamstrings. Some other types of resistance is going to be open and closed kinetic chain exercises. So open chain involves motion to where the distal segment, usually the hand or the foot, is free to move in space without causing motion of the adjacent joints. Typically will be performed in not weight bearing positions. The closed chain exercise is the opposite, where it involves where the distal segment, proximal segment, or distal segment is fixed while the proximal segments move. So for examples, for the upper extremities in a closed chain, that would be, to where you would do like quadruped or press ups from a chair, wall push-offs, prone push-ups. And in the lower extremities, that would be like lunges, squats, step-ups or step-down exercises or heel raises. So for open chain, so it depends on a lot of times the different diagnoses too. So open chain can improve performance of individual muscle or muscle groups more efficiently. So you're really targeting more specific muscle groups. So a single joint versus a multiple joint is going to be more open chain. And then if you want more joint approximation, then you want to perform closed chain exercises in weight bearing. Although this does increase in joint congruency and therefore will provide more stability during the exercise. So a closed chain, you're weight bearing and co-contraction of agonist and antagonist muscles, and this helps improve dynamic stability. And this will help stimulate joint and muscle mechanoreceptors. So just make for sure there is a precaution of high load open chain exercises may have an adverse effect on unstable, injured, or recently impaired joints, such as the ACL deficient knee. So when it comes to proprioception, kinesthesia, and neuro, so after soft tissue or joint injury, proprioception and kinesthesia may be disrupted and alter the neuromuscular control, so you need to be aware of that. So it's important to reestablish sensory information from the injured region by, initiating and controlling of movements. And it's definitely a high priority in rehab. And it has been shown that if you improve proprioception, kinesthesia will improve after rehab after the ACL reconstructed knee. And to do that, you would be doing closed chain exercises, because this will elicit a greater proprioceptive and kinesthetic feedback compared to open chain training. So with using multiple muscle groups, and they're activated across several different moving multiple joints, closed chain exercises will trigger sensory receptors in a greater number of muscles and intra-articular and extra-articular structures. So obviously, closed chain exercises are the obvious choice to improve upright balance and postural control. So preparation for resistance exercise. So you want to select and prescribe the form of the correct resistance exercise that is appropriate to be effective. You're going to be choosing between manual or mechanical resistance, or maybe even both. You're going to implement mechanical resistance exercise, determine what equipment is needed and available, You'll review the goals, the outcomes, and the goals of the patient. You'll explain the exercise plan and procedure, either that be to the patient or the caregiver to understand and making sure that they give consent. You want to have the patients wear non-restrictive clothing and supportive shoes during exercise. And obviously, it's important for them to perform on a firm and comfortable surface for exercise, and you're going to demonstrate each exercise in the desired movement pattern. So it's always good to make sure you look over all this implementation of resistance exercise, of the warm up before and cool down after, placement and stabilization. We're going to look through all of this information during lab. Some precautions for exercise. Obviously the Valsalva maneuver, looking for substitution of motions, and also overtraining or overworking. Need to also be aware of exercise-induced muscle soreness. That would be acute muscle soreness versus the delayed muscle soreness that was already mentioned. But the DOMS is usually noticeable in the muscle belly or at the myotendinous junction, and that usually occurs 12 to 24 hours after exercise. Early investigators, they did propose that metabolic waste accumulation theory to where it suggested that both acute and delayed muscle soreness was caused by the buildup of lactic acid in muscles after exercise. But multiple studies have shown that it requires only about 1 hour of recovery after exercise to exhaust to remove almost all lactic acid from skeletal muscle and blood. So that would be a myth. So early investigators proposed that metabolic waste accumulation theory, which suggested that both acute and delayed onset muscle soreness was caused by buildup of lactic acid in muscle after exercise. So this is not true. So for prevention, there is definitely little evidence to support if a warm up and cool down, for prevention, will progress the intensity and volume of exercise gradually. There is evidence of use of repetitive concentric prior to eccentric exercise will reduce muscle soreness. So make for sure that you look over all the contraindications of resistance exercise. If a patient is experiencing severe pain, especially during movement against no external load, that dynamic resistance exercise should not be initiated. And if a patient experiences acute muscle pain during a resisted isometric contraction, resistance exercise should not be initiated yet. And if a patient experiences pain that cannot be eliminated by reducing the external resistance, the exercise should be stopped altogether. If a patient has inflammation, dynamic and static resistance training is absolutely contraindicated in the presence of inflammatory neuromuscular disease. So for example, if a patient has acute anterior horn cell disease such as Guillain-Barré, or inflammatory muscle disease such as polymyositis or dermatomyositis, resistance exercise may actually cause irreversible deterioration of strength or damage to muscles. Dynamic resistance exercises are contraindicated in the presence of acute inflammation of a joint. The use of dynamic resist exercise can irritate the joint and cause more inflammation. A gentle setting exercises against negligible resistance are appropriate. If someone has severe cardiac or respiratory disease or disorder associated with acute symptoms, this would be contraindicated for resistance exercise. So for example, if you have a patient with severe coronary artery disease, carditis, cardiac myopathy, or congestive heart failure, or uncontrolled hypertension or dysrhythmias, they should not participate in vigorous physical activities, and that would be included in a resistance training program. After an MI or a coronary artery bypass graft surgery, resistance training should be postponed for at least 5 weeks. That includes participation of 4 weeks of supervised cardiac rehab endurance training until clearance from the patient's physician has been achieved. So all of the other is about lab content. that you can go over. Make for sure that you look over the PNF patterns, and by definition, you'll be going over PNF patterns in the future. But you definitely need to know about the definitions for each one. Let's see. And making for sure that you look over the different types of exercise equipment and equipment for stabilization that can be used, and different types of equipment for closed chain exercises. And that concludes our lecture for today. Thank you so much.